Good morning, everyone, and thank you for the invitation to speak to you guys today and for the opportunity to educate you on the role of Mohs surgery for melanoma. Here are my disclosures that are not relevant to the topic of discussion today. And as an outline, I'll be describing Mohs micrographic surgery and describing the appropriate use criteria that we use to define when we should use Mohs surgery. And then finally, review the various comprehensive histologic evaluation techniques, whether that be slow Mohs or Mohs with immunostains. So Mohs micrographic surgery, this was a technique that was first started in the 1930s by Dr. Frederick Mohs. And this is frozen section, 100% microscopic tissue margin examination. And this technique allows for precise excision and mapping of the tumor. And it allows us the ability to immediately re-excise residual cancerous tissue on the same visit. This allows for maximum conservation of normal or non-cancerous skin, and it has the highest evidence-based cure rates for skin cancer. So a little bit about the procedure itself. It's done in an outpatient basis, usually in the clinic setting in an exam room. It's very safe because we use local anesthetic, so this obviates the need for the operating room and general anesthesia. And again, we have the luxury of being able to remove the tumor and perform the reconstruction on the same day. And with this technique, we're able to decrease surgical morbidity because we're preserving normal tissue so that we're able to provide the least complicated repair or reconstruction possible. So this is a schematic taken from the American College of Mohs Surgery. So why do we do Mohs surgery? It's because the roots of a skin cancer often extend beyond the visible portions that we see with our naked eye. And if these roots are not removed, the skin cancer will recur. So here's a schematic here. Local anesthesia is injected in the office and we numb the entire lesion. And the visible portion to our trained eye is removed and with a very small narrow margin around the tumor, typically for non-melanoma skin cancer, 1 to 2 millimeters, a little wider for melanoma, that we'll describe later. And once that's removed, we stop the oozing and we put a temporary bandage on while the surgeon brings the tissue to the on-site lab. We section the tissue and we ink it with dye and we map it out on a piece of paper. The histotechnician then divides the tissue and freezes it and then mounts it on the cryostat, which is a device that cuts the tissue. And we process it in a way where we cut the tissue in a horizontal or flat fashion, and we put it on a slide. Once that's mounted on the slide, it goes through a series of various stains, and then it's finally brought to us, and we're able to examine the slide under the microscope, and we're able to view 100% of the margins, meaning we're able to see all the peripheral or surrounding margins and also the deep margin. And with that map on my side, I'm able to target and map out exactly where there's remaining skin cancer. So then I go back into the patient's exam room and we're able to cut a little wider, a little deeper, depending on what the map dictates from my read. And sometimes that process it's one cut, sometimes it's several cuts. It truly depends on the cancer itself. And once that is completely removed, then we're left to deal with the defect, whether we do a skin graft, a flap reconstruction, or even a linear line repair. So how does that differ from conventional excision? So when we simply excise with a wide margin, we take that margin and we create an ellipse that we see here, because usually we're immediately closing the defect. And I want to highlight here, I want you to pay attention to that peripheral tumor that's depicted here. So when we take that specimen out, we send that typically to the outside lab. And here the lab processes it in a bread loaf section fashion, meaning we cut in a vertical way through the tissue, and typically you will get about 6 to 8 slides per specimen, depending on how big the piece is. So here it's a pretty accurate example of the 6 slides that we would get from that specimen. And from these 6 slides, here you would say that all the margins are clear. However, we're not able to capture that outside peripheral deep margin. So that's seen here, and we're not cutting into that section. So this differs from most micrographic surgery because typically when I remove it only in that circular fashion, because I don't have to cut those and I don't have to remove that ellipse yet. So once that's removed, again, it's highlighting that external deep tumor island here. And it's sectioned by the histotechnician, but the way that we mount it is we mount that bottom, that deep margin onto the glass slide, so we're able to see it directly. So rather than cutting it vertically. So I know it's hard. It's very hard to explain to patients, but sometimes I describe it as like a Reese's Pieces cup, where we're truly inverting the specimen so that we're able to see everything that's closer to your skin and first. So the flaws of conventional excision is that when we do those serial vertical cross sections, or the bread loafing, where in studies, we're only actually examining less than 0.1% of the true at-risk margin. So when you're sectioning at those normal intervals, there's a 19% chance of detecting a positive margin at those normal intervals. And in an ideal world, we would have to cut at very tiny intervals of 0.1 millimeter in order to detect 100% of the positive margin. So that's where some of the criticisms of conventional excision exist. So then why aren't we doing Mohs surgery for every cancer? So frankly, it would definitely be overkill and would exhaust the healthcare system. It's typically not used in locations where there's lots of tissue reservoir, so the trunk and extremities, where tissue conservation is not as critical. And also the recurrence rates are not as high in some of these lower risk areas, and I will further expand on. So this led to a group of dermatologists from the American Academy of Dermatology and other boards such as the College of Mohs Surgeons, the American Society of Dermatologic Surgeons, and the Mohs Society. About in 2012, there was a consensus statement where we attempted to define the appropriateness of Mohs surgery dependent on the tumor type, the location where it occurs, the size of the cancer, and the patient characteristics. And even back then, with Mohs with immunostains in its infancy, it deemed that Mohs was probably appropriate for melanoma in situ or lentigo maligna on various locations, including high-risk locations, including the cheeks, forehead, scalp, neck, jawline, and the shins. Even higher risk areas are the mass distribution of the face, so meaning the central face, the genitals, the hands, feet, and ankles. Tumors where incomplete excision has been performed is usually indicated, and for recurrent tumors, that's probably also appropriate as well, and not dependent on where the location is. So moving on, so there's a body that you probably are familiar with, the National Comprehensive Cancer Network, which is a multidisciplinary group of various cancer experts that they gather and formulate guidelines for various tumor types. And fortunately, melanoma, we have these. So the NCCN guidelines for melanoma excision, when we look at the data that's used to make those recommendations, they're based on 6 randomized prospective trials where the overwhelming majority, 99% of those cases, were melanomas on trunk and proximal extremity. So that's what we're basing our treatment recommendations on. And when you look at specialty sites, meaning high risk, head and neck sites, or genitals, hands and feet, the melanoma margin trials only included 37 melanomas. So that represents less than 1% of what the population in those guidelines are. We now know that anatomic location is a crucial predictor of complications and complexity of conventional or normal wide local excision. So for that reason, Mohs micrographic surgery fills a gap in the NCCN guidelines for melanomas that are on specialty sites. So again, I want to highlight on specialty sites, so not for everyone. So I want you to, think of this as a pretty simple, rule of thumb. So rule of twos and rule of tens. What does this mean? So rule of twos, this pertains to the complication rates after conventional excision of trunk and proximal extremity melanomas. So these are what we call lower risk sites, and lower risk because there's only 2% risk of upstaging the tumor after it's been completely removed. There's only a 2% risk of having a positive excision margin when we excise the typical margins that NCCN recommends. And there's only a 2% chance of local recurrence. However, the rule of tens, this applies to the complication rates after conventional excision of specialty site melanomas. And here you can see the drastic difference. There's a 10% risk of upstaging the tumor stage. There's a 10% risk of having a positive excision margin when we use those recommended excision margin recommendations, a 10% risk of local recurrence. And here's another 10, so although not a percentage, there's a 10% increased likelihood of having to do a more complicated reconstruction, such as a flapper graft. So this is this is what I use to explain to patients when I'm describing why Mohs is a preferred modality on these specialty sites. So because of all this, so there's been a great, body of knowledge that's been in the past decade on Mohs for melanoma. So in the NCCN, acknowledges and incorporates this literature into some of the recommendations now, where Mohs may be considered for minimally invasive T1A melanoma. So these are melanomas these are superficial melanomas that are less than 0.8 millimeters in Breslow depth, and also without ulceration in anatomically constrained areas. So these are specialty sites, face, ears, and acral sites, meaning the hands and feet. And when Mohs is not available, you can use other modalities such as stage excision, where you're doing comprehensive histologic assessment. When Mohs is performed, it's critical that central deep bulking specimen that we remove is either sent for permanent section analysis or frozen section and cut in that vertical fashion in order to truly analyze the depth of the melanoma, because that provides the full staging information. This is in the finer print of NCCN guidelines. So in specific situations, so for large or poorly defined melanoma in situs, in lenticle maligna, which are melanomas that are arising in chronic sun-exposed skin, or in acral lentiginous subtypes, again, the ones on hands and feet. And then the ones, again, with a very minimal invasive component, the superficial ones that are less than 0.8 millimeters. They acknowledge that surgical margins of greater than 0.5 centimeters may be necessary, and techniques for comprehensive histologic evaluation and margin should be considered. So when it's not available, we know that in these locations, excision and margins of even greater than a centimeter may be even needed. But they strongly advocate that if Mohs is performed, to incorporate frozen section immunohistochemistry strains to assist in accurate interpretation. So I'll expand on that in the next slide. So the two methods of comprehensive histologic examination are slow Mohs, and how does this differ? So this is an outpatient procedure, also using local anesthetic. However, here, the specimen is sent for a stat permanent section. So we rely on the outside dermatopathologist to read this in their lab. And the inconvenience here is that it ranges anywhere from 1 to 3 days for the turnaround time to let us know whether we need to cut more or if the patient is ready for reconstruction. So because of that, the entire process may take up to 2 weeks. So meaning that the patients may have an open wound for that duration. That differs from what we call MOHS with immunostains, because here we're removing the tumor layer by layer in the office, but we have real-time updates because we have an on-site lab where we're able to see the melanoma cells with immunostain called MART1. However, for those who have had MOHS surgery before in the audience, this differs from conventional MOHS because each cut takes 2 to 3 hours to get a result because of the special processing time or processing it takes to highlight the melanoma cells. And the benefit here is that we have the definitive surgical treatment and reconstruction that can be performed on the same day. So MOHS with MART1, why is the special stain needed? It's because the atypical melanoma or melanocytes are very difficult to visualize in conventional frozen section, which is hemotoxin and eosin. So we rely on the immunohistochemistry stain to aid in highlighting the melanocytes or melanoma. There are various ones that that can be used to see the melanoma cells, but the one that's more popular, more conventional is MART1, and it's been shown to have superior sensitivity compared to other melanoma markers. There's also been validation that MART1 frozen sections are as accurate as the typical, permanent section slides that we send to the outside pathologist. And here we retain the most advantage of having the pathologic assessment of the entire surgical margin and increasing the ability to identify the subclinical tumor. So I want to highlight some important papers looking at MOHS versus excision for head and neck melanomas. This is a systematic review, which is a high-level evidence of looking at wide local excision and MOHS with and without immunohistochemistry. So LR here represents local recurrence, and I want to highlight here in the systematic review of 60 studies that the wide local excision recurrence rate for head and neck melanomas was greater than 7%, almost 8%. When you look at it for MOHS surgery, without immunohistochemistry, which was the way that we used to do it probably 15 years ago, better, but still, still not great. And then with the incorporation of immunohistochemistry, we further reduced that recurrence rate from 3.3 to about 0.5%. And this has been replicated in a University of Pennsylvania cohort. They also saw that the local recurrence with MOHS surgery of only about 0.5% for head and neck melanomas. And for excision, they had a local recurrence rate of almost 10%. So here are some slides I want to show you. So this is a typical H&E slide of a melanoma slide. So we produce both normal slides because this aids the immunohistochemistry slides, but it's hard for you to interpret. But trust me, this is a very difficult slide to interpret. What's melanoma, what's melanocyte, what's a normal skin cell. And so that's why we rely on the immunohistochemistry stain. So here we have a chromogen it's tagged by the antibody, and there's a chromogen that then highlights that antibody. And here you can see in this run here that there's increased melanocyte density, and here there's even a nest. So that signifies that that's melanoma in situ. So then I have my map to the side of me, and I'm able to mark that peripheral margin, and I'm able to go back immediately into the patient's room and re-excise that surrounding margin. So I want to close now with a case of mine, so showing the pitfalls of regular excision on the face. So this is a patient of mine who had a remote history of another melanoma on the nose back in 2006. When I first met her about 3 years ago, she was diagnosed with a separate melanoma in situ on the right cheek, highlighted here. So this was at a time when I was not doing MOHS with melanoma. stains yet in the office. And I did the conventional excision with 0.5 centimeter margins as recommended by our dermatology literature, by NCCN guidelines. And from the read from the pathologist, it was read as margins free. And this was immediately closed. So highlighting again where we convert that circle into an ellipse so we can do that immediate closure. She did well for about 20 months or so. And then in 2024, she unfortunately developed pigmentation along that scar, was biopsied again and confirmed a recurrent superficial melanoma here. So at this point, we were up and running with our MOHS with MART1 immunostains, and that's how I chose to treat her recurrent melanoma at this point. So all these circles, they mean something to me, but I'll translate to what they mean. So that inner circle is the clinical margin of the melanoma, so what we see with our naked eye. And then we take another 2 millimeters around it, and that's the piece that's taken for that central deep bulk. So that is processed in a vertical fashion for us for frozen sections, and also sent to the outside lab to further confirm that there's no true invasive component as recommended by the NCCN. And that outside margin is what is the true margin for MOHS. And then that's taken with an additional 2 to 3 millimeters. So we don't deviate from the the recommendations. We are still approaching it with the 0.5 millimeter margins for melanoma in situ, and for those rare superficial ones, we do take that full centimeter margin for superficial melanomas. So that previous, the histology slides were actually for her. So I did have to go back in for a second stage. And I want to highlight some of these dimensions because it's critical to know that, the 0.5 centimeter margins is definitely an underestimation of the margins that's needed to clear these tumors, especially in patients in South Florida that have a lot of sun damage. So her initial biopsy specimen dimensions were only about 1 centimeter, and her ultimate defect size was almost 3. So I definitely had to go way beyond the 0.5 millimeter margins to clear her, albeit she did have a recurrent tumor, so those often do require, wider resections. So the take-home points here. So the goal of MOHS surgery is 100% margin evaluation for complete tumor removal. It allows precise mapping for maximum preservation of normal skin. It's an option of providing same-day treatment and removal of the cancer and reconstruction. Most of the immunostains can provide lower occurrence rates and should be considered for high-risk sites only, so not for every melanoma that's out there. And thank you so much for your attention.